a system where early detection becomes a right and not a privilege. Many thanks, Ibrahim Habidu, for that background report. And now joining us to discuss equity for all in cancer care. Let me make welcome here in the studio Professor Abubakar Mohammed Bello. He is the President, Association of Radiation and Clinical Oncologists in Nigeria. Thank you very much for joining us again.
Thank you for having me. It's always a pleasure to be here to talk about something that affects literally each and every one of us, which is cancer. Always a pleasure.
All right, many thanks, Prof. Also here joining us for the conversation is Dr. Usman Waziri, Director, Cancer Prevention and Control at the National Institute for Cancer Research and Treatment. Many thanks for joining us, sir.
Thank you for having me. It's a pleasure to be here.
All right. Thank you. Welcome, gentlemen. Let's begin with Professor Mohammed. Let's look at the big picture. When we talk about equity in cancer care, what really does it mean in the Nigerian context?
So when you talk about equity, basically, you want to see that every cancer patient is taken care of, regardless of where he comes from or his financial background. So that's the equity in cancer care. In Nigeria specifically, you do know that we have so many new cancer cases, about 120,000 every year, and out of which over 70,000 die within the first 1 year, which means that a lot of them are not accessing care for so many reasons, some financial reasons, some where they stay, and so on and so forth. There are a lot of improvement, towards equity in cancer care in Nigeria. Over the last couple of years, we have been able to have more. We had only like 2 centers 10, 15 years ago. Now we have about 10 cancer centers in the country, and access even to experts like clinical oncologists, where I have the honor to lead, the clinical and the radiation oncologists in this country was so few. Now we have over 150, with about 100 active within the country. So there is a lot of things that are developing. And even government is really showing a lot of renewed commitment toward, enhancing cancer care around the country. They are putting so many things in place, like supporting indigent patients with the Cancer Health Fund, and so on and so forth. Now, having said that, we do know that there are a lot of challenges as well, towards equity. The cancer centers primarily are located maybe in the southern zone as compared to the northern zone. Even the expertise are primarily in a particular region, is not spreading completely around the country. And training also is such a very big, important thing. So in our organization, we have tried to identify how do we close the gap, in terms of equity. And we have looked at about 4 different pillars. Number 1 is professional expertise. We want to make sure that every oncologist, wherever you are practicing, you are doing the best clinical practice, best global practice. And we are also encouraging continued education of the professionals. The oncologists are properly trained all the time. And we have also looked at infrastructure and access. We want to encourage the government. We've been, involving government in so many ways to see that new centers are created around the country. I'm happy to note that in the last 2 years, about 3 new centers or 4 actually have been created, and those that have been there in the past have also been supported. If you look at Enugu, you look at Benin, they have been there, but there were no machines and so on. Now they have radiotherapy machines, so they are doing a lot better than they used to be. So there are many things that have been done, towards closing the gap in terms of equity.
Equity. I thought you would also mention when you talked about equity, because for me, for most people, equity for all in cancer care, you want to talk about the fact that maybe there's more attention on the particular cancer than some others in the country. Is that also a challenge?
Yeah, so there are so many, like I mentioned earlier, that there are so many problems surrounding cancer care, and I was talking about the pillars that we have mentioned. We're talking of infrastructure, we're talking of access. So there are, of course, cancers that are more prevalent than others. So if we are able to reduce, take for instance, in females, if we are able to reduce the prevalence or to make early detection of 2 cancers only, cervical cancer and breast cancer, you would have been reducing the prevalence by almost 50%. So that is very critical. And in male, if you are able to reduce the prevalence of prostate cancer, for example, you would be able to reduce the burden of cancers in this country by about 35%. So that's significant.
Okay, many thanks. Dr. Waziri, let's get to you now. Prof has laid a beautiful background for us, for the conversation. Speak to us about what NICRAT is doing. We've had you a couple of times come on the show to talk about, the efforts being made by government and your organization. But as of today, are there more improvements?
Well, quite sure. Let me say, in terms of equity question, just as Prof rightly highlighted it, ensuring equitable access to care regardless of socio-economic background. And in that regard, I think quite a lot has actually happened from the time we were here till date. For example, in the area of ensuring deployment of services, cancer, across the spectrum of cancer care, right from prevention through to early detection, treatment, as well as palliative care. I think government has invested hugely in that area. The current administration, I think, for the first time, we are able to deploy. There was a capacity building regarding basic cancer prevention services, early detection, to improved outcome of treatment. And this was done last year across the 6 geopolitical zone on a pilot scale. And this year, there is a plan to improve that. The essence is there is an initiative that is being championed, an initiative of government, the current administration that has been championed through the agency, the National Initiative for Cancer Early Detection, Screening and Coordinated Access to Care. And this is actually aimed at deploying cancer care services, more especially in the area of prevention, awareness creation, as well as screening, with focus on cervical cancer and breast cancer, as rightly highlighted by Prof. By the time we are able to address the menace of prostate, breast and cervical cancer among Nigerian women, we've gone a long way in drastically reducing the burden of morbidity and mortality among Nigerian women. So in that regard, breast and cervical cancer, the Nigerian government, through the institute, has already constituted the National Task Force on Cervical Cancer Elimination. This is aimed at operationalizing the prevention, vaccination, preventive services, as well as early detection. The good thing about cervical cancer is you can detect it early, the precancerous stage. So part of the initiative is to ensure that those with precancerous stage have access to treatment and are treated effectively. Already, stakeholders engagement, mapping has already been concluded. November 17, the program will commenced. We'll launch the program within southeastern region. So in that regard, that is driving access, equitable access, ensuring that the hitherto less underserved population of the country are actually covered and are provided with access to services. And that is not alone. There is effort, as I mentioned earlier, coordinated access to networked care. Why that is there, the government looked at it to address the gaps in terms of facilities, the gaps in terms of personnel. There has to be an effort to coordinate and link this screening, it makes no sense when you screen a woman or a man with cervical for cancer and you cannot link him up with treatment. So the part of the program is ensuring that whoever got screened at these facilities for the first time, by November this year, the government will be launching 8 federal institutions facilities institutions with that are equipped with facilities to do high-tech screening for cancer, with focus on 5 common cancers in the country. These are breast, prostate, cervical, liver, and colorectal cancers. So these centers will now serve as hubs where patients from whatever background can be linked to and get access to care. And it's still in part of ensuring equitable access. When you deploy services, the next thing is affordability of care. As rightly highlighted by Prof, this government, through the agency, is working tirelessly in ensuring that we improve National Cancer Health Fund. Cancer Health Fund has been in existence in this country since around 2021, 2022, but with the comment of this government, efforts have been on ground to ensure that we've expanded the services, just as you said, in terms of coverage and in terms of facility centers that are under this National Cancer Health Fund. And the primary essence of that is to ensure that the underserved, the less privileged, looking at the cost of care, have access to support for purchase of care. And with that, we'll ensure that as we are screening, numbers are increasing, the government is making effort to expand this. Already, there has never been a budget line for childhood cancers. In this 2025 budget, government has dedicated a budget line domiciled at the agency to support children with cancers, because for quite some time, these are areas that have been neglected. So when we talk of equity for care, you see, it's not only limited to the socio-economic background, even the age. For quite some time, children with cancers, people have not been talking much about them. As a pediatrician, I know a lot of children are living with cancer that are not only preventable, can be detected early, and has higher potential for cure. So
but how soon all of this, I know the Sinca initiative is also there.
Yes.
How soon, or if that isn't already happening, will we begin to see impact at the patient level?
Yes, this is quite a very good question. Impact at the patient level. Already we've worked on the modalities and strategy for implementation. We have been in touch with local and international partners like St. Jude Global and Nigerian Society of Pediatric Oncologists. We've already engaged and mapped centers based on certain strategy and criteria, facilities-wise, expertise, and we've already identified that, and we've already developed modalities, and in the next couple of weeks, we are launching the commencement of childhood cancer fund support for children living with cancer. So by the end of this year, I'm sure a lot of Nigerian children will start benefiting from that. So okay. I think practically we are talking about that. In terms of Sinca that you've mentioned, already Nigerian government in this current dispensation through the institute has already trained over 200 Nigerian young researchers, oncologists, scientists in the area of cancer field for high-tech research that is not only reflective of the scientific progress, but the lived reality of Nigerian patients, to see how we can base our policy formulation, our practice in the area of oncology to address Nigerian cancer challenges.
But let me take that to Prof, because one issue we still do have is uneven access between the urban and rural areas. In your opinion, what single policy could be that game changer to close the gap?
So, you see, there are different levels of cancer care. When you start talking about prevention, for example, that should spread all over. Waziri was talking about cervical cancer, which is actually a preventable disease. You don't even have to allow it to even develop to precancerous condition because there is a vaccine, right? And there's a vaccine that you can actually use for young people to be able to prevent that cervical cancer from developing in the first instance. And Nigeria actually has keyed into the global initiative of the 1970-90 of the World Health Organization, where it's expected that about 90% of children would be immunized, with the human papillomavirus vaccine. And Nigeria has done so well. So far, we have been able to immunize about 50 million, children in this country within the last 2-3 years, which is so fantastic.
Now, vaccination is still ongoing at the moment.
Sorry?
At the moment, is the HPV
So it's an ongoing thing,
Yeah.
It's not like it's a one-time thing, it's a continuous process, but Nigeria has successfully been able to vaccinate this number, which is fantastic. And with the fact that now we know that 1 dose of the vaccine is sufficient as compared to previously we thought it was 3, then it became 2, and now studies have shown that even 1 is enough to prevent children from contacting the human papillomavirus and developing cervical cancer. So that is one area that is low-hanging fruit, okay? But the area that is really, really quite difficult now to have is that we have equal spread of cancer centers across the country. And I want to believe, for me, is that federal government alone cannot do it. State governments must key in to be able to provide cancer centers because it's doable. States should be able to provide. There are about 28 states in Nigeria that have no presence of any cancer institution or comprehensive cancer centers, as it were. There are no radiotherapy equipments, basically. So, and that is huge. So that means patients from rural areas need to travel to urban areas to access care. Sometimes they can't even afford to go there, and even when they get there, the cost of the treatment is prohibiting, and so on and so forth. So these are very important things. But Nigeria has developed the National Cancer Control Plan, where there are, clearly defined stages of how to close this gap, in terms of screening, in terms of treatment, in terms of prevention, in terms of palliative care. And it has been costed many years ago. But unfortunately, there is no funding, there is no backing, financial backing to be able to implement this. In this country, it has not yet been institutionalized to have screening, for example, nationally for cervical cancer. So most of the cervical cancer screening are being done individually and by NGOs that encourage cervical cancer. So it's not institutionalized, it's not a must, but it should be a must that women should go for cervical cancer screening, because this is of national importance, right? Because patients that develop cervical cancer have so much, not only disease implication, but also economic and so on and so forth.
But the cost of screening is also a challenge for a lot of women.
And that is why the National Cancer Control Plan has developed templates where they can crash down the cost if implemented by government. It will crash it. Take, for instance, the human papillomavirus vaccine. Until it is now implemented, it was so expensive. But now government has taken the fight and have provided all the necessary vaccines across the country, and because of that, people are keen in. So the same thing can happen even to screening of cervical cancer. The same thing can happen to screening of prostate cancer. The same thing can happen to screening of mammogram.
What about professionals, in this field? I'm talking about people like you. You talked about 100. Is that sufficient?
Not really. It's really grossly inadequate. But that is the story of sub-Saharan Africa, really. And even the ones that were training are now JAPA. I learned that JAPA now is an English word. It's in the dictionary, so I can comfortably say the JAPA, So that is one of the key areas. But we have, as organization, have looked of areas where we need to work quickly. And one of it is to provide, to make sure that we engage government to provide more training, more doctors to become specialists in cancer care. And that is one of the things that we are doing. But it is so small, it is so meager. Every oncologist now in this country is taking care of 2 million people when you are supposed to be taking care of less than 100,000. So you can do the math. So everyone has a burnout syndrome, and most of them have acute fatigue syndrome. The last time one of my younger residents actually collapsed in the hospital because of overwork. There are not enough.
Not enough. What about infrastructure?
Here, so that we remind the viewer to send in their messages. Of course, emphasis on short messages. The number is on your screen, just so that we can take a number of them as the conversation progresses.
All right. Being an expert in the field, what would you want to say? What areas should government focus on in terms of infrastructure that can help you get the job done better and faster?
So infrastructure will not only entail providing equipment, it should provide training as well, because machines don't treat patients. It's the human that train. So human development should be the number one thing. And that is why we have gone to make sure that there is an established training faculty in the National Postgraduate Medical College, as well as the West African College of Surgeons, that are primarily training oncologists like us, that are using radiation therapy, chemotherapy, targeted therapy for the treatment of cancer. And we don't only do that, we do advocacy, we do so many other things, engage policymakers to make sure that these things are institutionalized. So that is the first most important thing. Because when you talk of infrastructure, generally you are thinking of providing machines, radiotherapy equipment across the country. Where are the people that will man those machines? And how trained are they to provide those services? So these are the most important to my mind. And in fact, for our organization, for our association, what we think is the low-hanging fruit is to train people, more training in oncology departments. If you go to most of the centers now, you'll be surprised that there are very few residents. So as a professor of oncology, I still do the same thing that I have done 20 years ago. Sometimes I clerk patients because simply there is no one to do it. And I work with only one resident most of the time, when I should have about 10, 20 so that they will learn what I have learned over the years. But simply the doctors are not there, and government should make concerted effort to employ more.
When you talk about the professionals, is it just the doctors? What about the technologists, the technicians, those who deal with the machines you're talking about, yes, right?
So I'm talking, from up and down. So I'm going to come down. The position of leadership always is with the doctors. So that is why I'm concentrating, and that's the association I'm representing. But suffice to say, you're absolutely right. You're absolutely right that it's not only technicians. In fact, there are a lot, support staff. Support staff is very critical, and they are dwindling. About 3 of my medical physicists at the National Hospital just walked away about a month ago and got another job in the UK.
They didn't walk away, they flew away.
Well,
all right.
There's so many words that can be used.
Let's talk about...
And one individual now is supposed to continue their job. And there is no replacement. And nobody is even talking about it. Nobody is talking about it. How do we replace these people? And the work keeps piling up. And he had to go for a training in South Africa, and we had to keep some of the treatments until he comes back, because there was nobody else to do it for them.
But replacement naturally will come from the universities. I don't think there's anywhere else to get replacements from.
Excellent.
You train more, you keep
excellent.
training.
So
and they are training, right?
No. So excellent. Yes, they are training, but they are not enough. And a lot of them are not being employed. And that is why we are talking of government making concerted effort.
Okay.
We must make concerted effort to train. We must make concerted effort to employ.
Okay.
If you train and you are not employing, then it's as good as you are not doing anything.
All right. Dr. Waziri, let's talk awareness, which remains a challenge, I mean, especially among low-income communities. So how can traditional and the social media be deployed to drive early detection and support systems more effectively?
Yes. Awareness creation and public education, generally regarding in the areas of health and specifically cancer, is really very strategic in terms of raising and improving people's perception and attitude towards the disease. And in that regard, our government is doing a lot, and there's still more room for improvement. Like currently, we have a plan, a costed plan, funded by government, about to be rolled out. Also, in the area of multi-pronged approach to awareness creation. And I mean through community sensitization and community engagement, branding of traditional community influencers, traditional rulers, religious leaders, as well as community-based organization leaderships as ambassadors to create more awareness and informed and influenced decisions and thinking of the people at the grassroots regarding cancer. Then the social media also, as well as digital platforms, we've engaged quite a number of consultancy firms, and the government is doing every effort to ensure that that has really been kick-started. Then, so also in the area of government agencies also, we have developed a robust plan, a sort of partnership and collaborative plan, strategy to engage sister government agencies like the NTA, the National Orientation Agencies, in the area of awareness creation. And we're equally utilizing school institutions like schools and National Youth Service Corps to really raise that awareness regarding cancer care, cancer itself, to demystify. A lot of information, communication, and education materials have been developed by the Institute, and we've shared them in 2024, and we are still distributing them. The second batch of distribution will commence, and we are targeting institutions like hospitals, where you have patients and people coming for care, schools, more especially secondary schools, as well as primary schools, and then tertiary institutions also. Then, market women organizations, we are using them. Farmers, we've had a pilot community-based engagement in Plateau States, in Kebbi State, in the north, and then in Ogun State, and in Rivers State in the south, trying to form a model, developed a model, a form of communication strategy development that would develop community communication, cancer communication to the community. The findings and learnings from that, we use it to build upon what we are planning to roll out very soon.
But what about collaboration? Since you are talking collaboration for awareness, what about for cancer care? Collaborating with the NGOs, with private sector, to ensure that cancer care becomes more affordable and sustainable?
Yes. You know, we've initially discussed about awareness. In the area of care, cancer care, and this is one area that since the coming of the Institute, the government, through the Institute, has really been making a lot of efforts. Let's take, for example, the issue of policies and the issue of cancer control plan that was highlighted by Prof. When the Institute came on board, we realized that the National Cancer Control Plan needs to be reviewed. The Institute reviewed it and developed the National Strategic Plan for Cancer Control in Nigeria in line with the WHO request or requirement, and that has actually been launched 2023 to 2027. Got costed, and we've already started implementing it. Part of the implementation plan, we have the strategy for cervical cancer elimination, operationalization. In the course of operationalizing it, the Institute has already formed a task force committee and create partnership for the elimination of cervical cancer in Nigeria, PESIN, which got launched sometimes. And I think this is a very giant stride towards operationalizing it. Still in the area of partnership, you know, you need to have a needs assessment to know where we are and where we are going and to direct our activities. The Institute engaged international partnership, International Atomic Energy Agencies, World Health Organization, International Agency for Research in Cancer, and conduct a needs assessment, a sort of impact review in this country. That was concluded 2024. The report has just been launched and presented 2 days ago, and they just concluded ICW. That, the essence is to create this partnership, a holistic approach, a bankable document that would now guide us. And through it now, we have established that partnership. The IAEA are there. Then locally also, we have local collaborators. And that is guiding us to know where we are now and where we will be by the 2027, 2028.
Okay.
And that is exactly the blueprint we are operating.
Brilliant. Many thanks, Dr. Waziri.
And in terms of costing, I just wanted to put it in. Quite sure government is doing a lot because most of these activities, this present dispensation, based on the findings from this impact review, from the needs assessment, from the collaboration, most of the activities, we secured budget line for research in cancer. We secured budget line for prevention and screening services. We are, for the first time, this government is establishing nationalized or government-owned, taking ownership of screening services in the country. 8 facilities in the country at tertiary level will serve as hubs for screening of common cancers. And then there are plans to build out capacity through partnership that is established at the subnational level to take that ownership and ensure sustainability.
All right. We hope that, all of this that you have said would actually translate to reality, in a short time. But, Prof, I'd like to get to you as regards awareness. He's talked about awareness on the part of the populace. What about awareness in terms of other medical practitioners, not oncologists this time? Because, most times we talk about cancer, you talk about the fact that they present at late stages, and that's also increasing the burden for treatment and all. But, of course, we can deal with it or probably even prevent it if, when patients present at the hospital, the general practitioners who see them are able to refer them as early as possible. So there's also the lack of awareness on the part of medical personnel who are not oncologists. So what are you doing in that regard, just so that they are also skilled and trained to do the needful as early as possible?
Well, that's a very good observation. I must commend you for that, because we do know that from diagnosis to treatment takes about 3 to 7 to 1 year, 7 months to 1 year. And that is really one of the real reasons is that there is the differential of cancer is always at the backdrop of, clinicians when they are doing it. And having said that, government, not only government, even our organizations, we have participated in developing some cancer desk or some desk information that was supposed to be disseminated to secondary institutions as well as primary health care, because we believe that this should happen from primary health care. Primary health care is being strengthened, and they should be educated to recognize early symptoms of cancers. If we are able to do that, I know that government is working very hard to strengthen all the primary health care. They have put in so much money in the last 2 years. The Honorable Coordinating Minister of Health is an expert, and he has so much passion on primary health care, which should be the first, first step, when you are talking of health care, cancer care. So primary health care should be strengthened to be able to recognize, and that is the first way. And we must develop the referral process, where when somebody has index of suspicion, is able to send to the appropriate quarters. But it gets back to the fact that we do not have that prerequisite number of experts even to take care of those that have been referred. So there is that disconnect as well. And yes, there is continued medical education, not only for oncologists, but for general practitioners. We have been doing that. We have been doing webinars from our organization, from our association, to educate other doctors how to recognize early symptoms of cancers and to refer them to the appropriate quarters. You know, we are usually at the receiving end, because when you look at the chain of, you know, the process of making a cancer diagnosis, before it gets to the oncologist, who is the last person on the chain, you know, it takes several months. Now, you recognize that there is a symptom, you have a lump, somebody feels a lump on the breast, he's sent for mammography, the mammographer will do a mammography, and he will now send it for biopsy, and then the biopsy, you know, will be, that biopsy specimen will be sent to a pathologist. How many pathologists do you have in the center, you know, and how long will it take for him to make a diagnosis before they are now sent to the surgeon or sent to the oncologist, as the case may be. So it's a lot of, it involves a lot of professionals. Okay, it involves a lot of professionals that we do not have at this point in this country. So that is why late presentation for the not so distant future will continue, even if we are making all these giant strides that Waziri is talking about. It will take a while before we will clearly see the impact of what is being done. But if we are able, importantly, we are able to domesticate our professionals, support our professionals so that they don't need to japa. They can stay here, because I tell you, if you are working abroad, it's not the same as staying here. You know, some of us have had that experience so many years ago, and we decided to stay. Not because we are being paid fantastically, but because it is important to be here.
What can be done to make the medical personnel stay? What should be done? Is it about salary alone, or
no,
there are other
certainly
factors?
not. Certainly not. Otherwise, a lot of us will not be here. But provide an environment that is rewarding to work with. If you are looking for this equipment, you get it. If you are looking for that equipment, to get. People that come back from abroad develop private practice, and they are happy doing it. Not because of all the money they are making, but because they have put things in place. There is that chain of referrals. There is that equipment that is readily available. There is that nurse that is willing immediately to support this patient. There is that medical physicist that is there to plan the patient. There is that therapy radiographer that is always on the ground to treat the patient, and so on and so forth. All these things, we must have a systemic change. We must do something that will change the narrative around, you know, cancer care or around health system, that makes our professionals not to be just civil servants. Because what we have now is fundamentally civil servants. Everybody is in a hurry when it is 4 o'clock to leave, to go home, because he will miss the bus and he can't afford an Uber. So it goes round and round. The salary, there is no doubt about it. It is almost, how do I even put it? You see, 2 years ago, what I'm earning is 1/3 of what I'm earning today. So my salary when I was a house officer 37 years ago is more than what I'm earning today as a professor. Yes, when you turn it into dollar value. So this is where the problem is. We need to have an understanding. People complain they are japa, they this and that. How much money do they make there? But you see, and there is no, that's why I said it's easier to stay here. A little push from government. A little push from government will make Nigerians to stay, because we love this country. Nigerians are the most proud people on earth. Anywhere you go, anywhere in the world, you see a Nigerian, he will be proud to say, I'm a Nigerian. Anywhere. But there are certain things that we must put in place. And some of it is around not only around salary, but making the system work. Our health system need to be looked at. And that is why we are developing next year, hopefully we are doing a national oncology summit where we'll invite stakeholders, we'll invite government, we'll invite partners, the IAEA. They have programs that we have not keyed into as a country, you see, where we can get support. There are so many of them.
So if
and
you have
we're not
to,
talking about it.
If you have to, Prof, identify one priority that could define Nigeria's cancer response in the next 5 years, for the next 5 years rather, what would it be? We're running out of time.
Let us develop comprehensive cancer centers, one at a time, which we do not have. What we have today is cancer departments in teaching hospitals. It is not the same. We should have comprehensive cancer, stand-alone comprehensive cancer hospitals, where when you walk in, you said, I felt a lump, it will be done within a week.
And that
and
aligns,
everything is be put in place.
And that aligns with the message that we got here from Fram. He says he's Fram from Lugbe in Abuja. He says, good morning. Regarding this morning's conversation on cancer, we have a cancer center in Lugbe, Airport Road, that has been locked for years. I think the government should make that place a center for cancer research and treatment for the people.
It's not
I think
for
it
the
will
government,
place a mark of excellence for President Tinubu's renewed hope agenda.
He says it's not a government facility.
It's not a government facility.
It's not?
Yes.
But I thought it was established by government.
What are the reasons you think it's grounded?
Well, it has never, it's a long story.
It's never
we are part
taken
of it,
off.
but it has never, it has
It
never
never
taken
worked.
up. It's a private enterprise.
All right. So
I thought the first lady, the late first lady, had a hand in it, to help.
Late?
Yes,
She's
former.
not late, former.
Former late.
Yes. It's a long story, really. We are part of it, but the long and short of it is that it's not a government facility.
Oh.
But I think that there are people that are interested in that facility, and hopefully very soon it will come to.
All right, let's take some more questions now. This one is from Ahmed Baba Dikwa from Maiduguri, and it reads, to empower the public in the fight against cancer, stakeholders from health ministries to tech innovators must pioneer a simplified cancer surveillance system. This means moving beyond complex medical terms to create clear, accessible tools and guidelines. Another one says,
I agree with him totally, and honestly, we've been doing it. You see, Nigeria is 220 million people. It's not like Rwanda. When people talk that Rwanda is doing this fantastic, they are just 14 million. You see, so that is like Kano.
Okay, let's talk about India.
Yes.
India is also doing it.
Yeah, but India took a lot of years.
And India is 1.4 billion.
Yes. But there has been sustainability in whatever is being done. You see, every government will come and do one thing, and then after a while, another government comes and said, no, this one is not good enough. They change it and so on. Sustainability in health systems is what makes it
thrive.
So that is the challenge. It's not because we are 220 million
yes.
people.
So I'm coming to that. What I'm trying to say is this. You see, every government that comes puts in a lot of money. But whether that is sustained consistently is what makes the difference. I will tell you the story of India because I know. You see, when India, in the 70s, when Indians are scattered around the world, their health system was not such a fantastic thing. But they sat down and realized that, look, we need to put a lot of money in healthcare because healthcare can in itself be a business. So they decided to invite all their professionals within and outside the country and said, what is it that you need in terms of cardiology? Let's have hospitals that are specialists in cardiology. What are the things that we need in cancer care? Let's have hospitals. And they provided them with enabling environment, enabling policy, and even financial support. for them to be able to develop those hospitals. All the hospitals that our people go to in India are private.
And you know,
they don't go to government hospitals.
Nigeria can take a cue from that because we have professionals,
yes,
you know, spread across different parts of the world. Fantastic. Let's read some more questions. From our viewers. This one says there are more types of diseases that require government intervention, not only HIV and AIDS and tuberculosis, but also cancer, kidney disease, and other critical illnesses and conditions that the government is expected to manage through healthcare policies, funding, and public health programs. Now, this includes providing free treatment, palliative care, and financial support, as these diseases are highly prevalent in Nigerian communities and can lead to death if proper care is not available. Quite a long one from Chinda Gadsma. Thank you. Another one from Yusuf Abdul. Because of time, we cannot take it. I think we'll just take the final comments from Dr. Waziri as we wrap up this conversation.
Yes, I think quite a lot has actually been said, but let me start with the issue of the center alone, the airport road. Quite sure it's a private, it's not a government center, but I think one important thing that happened in the area of cancer care in the country is the establishment of an agency, the National Institute for Cancer Research and Treatment, in 2023. Quite sure a lot has actually been happening through silos activities with little or no coordination, but I think with the coming of the institute, a lot actually all these activities are now being streamlined, and government currently in the 2025 budget has already budgeted a significant amount for the takeoff of the establishment of a world-class cancer research and treatment facility in the country, to serve as the headquarters of the institute. That is in that regard. And then quite sure regarding workforce, this we've identified this, and the government has actually been doing a lot. Government was able in this current dispensation to brought together the institute, the Federal Ministry of Health, the Nigerian Universities Commission, the Federal Ministry of Education last year, and we had a National Oncology Workforce Summit. And this was aimed at developing strategies to really bridge the gap when it comes to oncology workforce.
Many thanks, Dr. Waziri. Because of time, we'll have to leave the conversation at this point. Many thanks, Professor Abubakar Mohammed Bello, President of the Association of Radiation and Clinical Oncologists in Nigeria. It was a pleasure to have you. Thank you. And we hope that you continue to encourage medical practitioners to remain just the way you have. Thank you so much. Dr. Usman Waziri, Director, Cancer Prevention and Control at the National Institute for the Control of for Cancer Research and Treatment. Many thanks for being our guest. And yes, keep up the good work. We hope to see you some other time to hear all that your organization is doing.
Thank you. It's a pleasure.
So that's our first conversation. We have a second leg on the program this morning, and that's on the brand new INEC chairman. Please stay with us. All right, welcome back. It's still Good Morning Nigeria, live on the network service of the NTA. Yesterday, if you watched the Nigerian Television Authority, of course, you would have seen the Nigerian Senate confirming Professor Joash Ojo Amukwetan